I think we'll move on to the next talk. Dr. Harshali will be talking to us on biomarkers in neovascular AMD. Dr. Harshali.
Good morning, everybody. So before we actually go to the OCT biomarkers in neovascular AMD, let us understand the newer nomenclature, where type 1 is the sub-RP MNV, type 2 is the subretinal. You can have a mixed variety, and the type 3, which is the RAP. So type 1 is basically when the membrane is under the RP, and it's more likely to maintain vision over time. Because these vessels are nourishing the outer retina, there's a less risk of developing geographic atrophy. However, it requires more anti-VEGF injections as compared to the other types, and you could have recalcitrant or sub-persistent fluid. The long-term visual outcomes are typically better. The type 2, where the membrane is above the RP, results in more of a fibrotic scarring as compared to the other MNV type, and that in turn results with a poor visual outcome. However, it responds faster to the anti-VEGF. The type 3 or the RAP is associated with higher rates of geographic atrophy and leptochoroid and retinal pseudodrusense. Very important that they may have the similar pathology in the fellow eye. So if you look at the OCTA, you'll see flow. In the type 1, you'll see flow under the RP. In type 2, you'll see flow above the RP. And in type 3, you'll see the flow coming in from the outer deep plexus to the outer retina. So coming to non-exudative macular neovascularization, this is typically seen in patients where we are treating the other eye exudative MNV. So double layer sign, as Dr. George explained, you have this separation of the RP from the Bruch's membrane. And Narita et al. Described when the length is more than 1000 microns, it could be harboring a MNV. So this is a case where clinically you don't see anything much. OCT shows just the double layer sign, but an underlying OCTA will show you a non-exudative MNV. Activity clinically, we have known that it is fluid, heme, and mixture of heme, fibrin, and exudate, what we now call as the SHREM. The location of MNV obviously has impact on the visual acuity. You'll have better visual acuity with the extrafoveal and juxtafoveal as compared to the subfoveal. Central subfoveal thickness is a biomarker. It has been used as a criterion in many drug trials, but wherein you consider less than 25% reduction as a criterion for reinjection, but it cannot be used in isolation because visual acuity would then depend on the fluid and the SHREM. In cases of geographic atrophy, a lower subfoveal thickness would actually indicate lower visual acuity. So distribution of fluid is one of the major biomarkers. If you have intraretinal cystoid fluid, it's associated with poor baseline visual acuity as well as poor visual recovery after the anti-VEGF treatment. It's associated with a higher risk of visual loss and development of fibrosis and atrophy. It need not be an exudative fluid, as Dr. George mentioned. You could also have degenerative cystoid spaces. Subretinal fluid is the exudation which occurs between the outer border of the photoreceptors and the RPE, and it's a better biomarker as compared to the intraretinal fluid. It's the most frequent fluid localization that you see in type 1 MNV, and refractory SRF may not have a negative effect as we saw in the fluid trial. PED is the separation of the RP from the inner collagenous layer of the Bruch's membrane, and less important for the visual prognosis. You could have a serous drusenoid, fibrovascular, or a hemorrhagic PED. Coming to RP tears, these are the most feared complications in neovascular AMD, which can happen either spontaneously or even as a result of treatment. And the factors which predispose are the large diameter of the PED, the increased vertical height, and the duration of the PED. Subretinal hyperreflective material, or the SHREM, is the hyperreflective material that you see between the neurosensory retina and the RPE, and it persists even after the anti-VEGF treatment. OCTA would help us differentiate from the vascular and the avascular components of the SHREM. Photoreceptor layer integrity, if you see the disrupted external limiting membrane and the foveal EZ band, that is associated with compromised BCVA at baseline and despite treatment. Hyperreflective dots are these well-defined circumscribed lesions that are around 20 to 40 microns, and these are actually the lipid-filled microglia cells. There is a persistence of high number of these HRDs in the non-responder patients. ORT are these apo-reflective surrounded by a hyper-reflective band, and these are the rearrangement of the photoreceptors and indicate poor visual prognosis. The anti-VEGF treatment does not decrease the development of newer ORTs, nor does it regress the older ORTs. So you can see ORTs in different stages of evolution, one where it has fully developed and one where it is in progression. Coming to OCTA, it yields new insights into the physiological and pathological blood flow of the retina and the choroid. It's non-invasive, the examination time is short, it provides a more broader and detailed picture about the morphology. It's possible to visualize and monitor subclinical non-exudative MNV as we saw in the first case, and these images can actually be translated into mathematical descriptions. So based on the morphological shape, you can have a C-fan, a medusa form, or a glomerular form. All these forms indicate an active CNV. Whereas these long linear vessels where there are no capillary ramifications, these are like a dead tree pattern and resemble the mature vessels which respond poorly to the anti-VEGF. The other biomarkers are the vessel termination, again the branching vessels, the vascular loops, and the anastomotic arcade along with this halo again are an indicator of an activity and tend to be treated. The Skalsbergs described these loose nets and dense nets. Loose nets were again these mature vascular lesions, whereas dense nets had higher proliferative activity and responded to the anti-VEGF. There are several other quantitative biomarkers and which can be combined with AI to show us the prognosis over time. This can be integrated in a AI dashboard, and then you can actually predict the outcome and the required treatment frequency. So this is all under current research. With this, I end my talk. Thank you.